Good morning, Dr. Chesnut. Attempt number 2. So thank you for being here. Now, I know you've got a pretty stacked diary, and like I said earlier, your time is appreciated. Now, of course, we're here to discuss, well, pretty much everything with regenerative and aesthetic medicine. But before we dive in, would you mind introducing yourself and how you ended up in this space? And by that, I mean this functional regenerative space, as I know you're obviously far more than just a quote plastic surgeon. We've done plenty, and to be honest, the longer your intro, the more time I have, as I mentioned earlier, to sort of get my adenosine receptors a bit more knocked out with a little more caffeine. It's been a long day, but yeah. Anyway, I'll shut up and let you get to it, and let you do your thing.
Yeah, thanks, Robert. Appreciate you having me. And my name's Cameron Chesnut. I am a facial plastic surgeon, very specifically. So if I were to go into my actual surgical practice, it's that. But it's a bit different, as you were sort of hinting at, in that I use a lot of regenerative medicine and a lot of things would classify more into the longevity space as part of my surgical practice. Patients travel to me. I'm in the Pacific Northwest part of the United States, and patients travel to me from all over the world for this sort of retreat experience as they're doing their anti-aging or rejuvenation type of procedures. And that's set up in something that kind of I divided into this pre-recovery phase, or I call it pre-covery during the actual surgery, and then a whole recovery phase and experience while they're here that lasts about a week. And it's very different than what you'll find typically in our industry, and it's very regeneratively based. And part of that, I think we're going to get into this later quite a bit, is just to enhance the durability of these procedures. I want them to last a long time when we do them, and I also want to do as little as I can from the get-go to hit the goals or results that we're trying to achieve. So that'll be, I think, be one of the questions too, is why are we doing this at all? And the more that we can lower the barrier to entry, the better the total outcome is, and we kind of go for a ROI type of look at it a little bit. So I got into this space just simply off of personal interest. My practice is my practice. I could be any type of surgeon, and this would be beneficial. So for anybody listening to this, there's a high likelihood that at some point you'll have a surgery, elective or non-elective, at some point in our life. And I think a lot of things we'll talk about are wildly applicable to all types of surgery, if it's orthopedic, if it's general surgery, or if it's something that's more elective, like in my world a little bit. And I love longevity for myself and my peak performance, and just for the same reason that we're all listening to this in the first place, for the benefits it gives us. But there's a lot of crossover and applicability, and using it in a post-surgical setting exposes some of the benefits that we can get just in regular life as well. And I was an athlete and still am, and highly competitive. That was sort of my identity and upbringing. And I've carried a lot of that mindset into what I'm doing now, from the way that I prepare myself and my patients, the way that I execute during surgery, and then really in the way that we're recovering afterwards. And when I was training and growing up and, competing, recovery was just sort of coming in to be something that people were talking about a little bit more as probably the most important part of our training. And now it's, very in fat, and people are talking about it a lot, but a lot of those mindsets carry over again to this post-surgical setting in ways that we can really enhance recovery, especially since we get to know essentially when that injury is happening or choosing it in a way. So that's a kind of a long-winded way of the different cross-pollinated facets that led me into sort of where I am today.
That's amazing. Thank you for that. Just on the sort of the functional integrative side, did you do any, I assume you did training beyond your traditional medical training, or are you like a fair number of physicians? Did you sort of pick a lot of this up as you went along?
Yeah, exactly. And it's interesting because when you look at who's in this longevity, regenerative medicine, functional medicine, whatever we want to call it space, it comes from all over because there is no particular board certification for it that's recognized by, in America, by the ACGME, we would call it. And so you're going to find, I think, interestingly, in a good way, you're going to find a sampling error of people that are just a little bit more avant-garde or progressive or thinking about things a little bit differently. At some point, I think it will narrow down in its specialization a little bit more, but you'll find very few surgeons. I would probably be on the more rare end, but more of the primary care specialties or um, physical medicine and rehabilitation. And one of my goals, objectives, and values is to sort of spread this to my other surgeons because I think that we underutilize it and we can maybe have some of the most benefit because, as we'll talk about when we get into a lot of these longevity things, everything's just magnified when we're in a really post surgical healing inflammatory state. That's when we get some of the most benefit out of a lot of these things.
Yeah, definitely. I think it ultimately comes down to the practitioner. And look, I've obviously not been through medical school. I've been through biochemistry school, but that's completely different. It's a desire for an individual to have, uh, of course, talking about the functional integrative side of it again, a deeper desire to understand the physiology and the biochemistry behind medicine. And correct me if I'm wrong, but I think some of that is definitely lacking in maybe in sort of traditional medical training. I assume you get as far as the Krebs cycle and maybe a bit more, but you sort of after that it's really about working through the traditional medical sort of framework, medical schooling framework, a lot of which is based off of pharmacology. And then as someone such as yourself, you specialize and you get caught up in that. But I think sort of bring it full circle for me, being someone who is really good at this sort of functional medicine stuff is fundamentally just having a love for biology, which you obviously emulate in spades. So, yeah, no, that's all points well taken.
That's a
Um,
really interesting point. And sorry to interrupt you because I'm
of
kind of
course,
thinking on the fly with you here a little bit about what we do learn and reflecting back on that. And I have had these reflections before, but as you just said, you're learning the Krebs cycle, right? Because we're going to talk a lot about mitochondria today, and this is what's driving them, right? And we learn about it, and at one point you're just rogue memorizing it. You have to memorize the Krebs cycle with no real applicability, right? Until, like you just said, you get into pharmacology. And not that that's not valuable and life changing and wonderful, but we're not, when we really get down to the root of it, like, well, we're not really talking about just the basic everyday regenerative functions that the mitochondria can have. It's interesting to really reflect on that. You're memorizing the Krebs cycle for applicability to pharmacology, not for its like daily function quite as much. And as we get back into when all of my colleagues start getting back or coming back into full circle of like, well, let's look at the mitochondria and how we can, improve their function. We kind of get back into the Krebs cycle, like, oh yeah, I remember, learning this back when, and then, you kind of like purge the information because it wasn't valuable. But, I think everything meets in the mitochondria a little bit here, and it's kind of fun to talk about.
oh yeah, no, for sure. I had the pleasure of interviewing Dr. Thomas Seafried, who I'm sure you're familiar with, the cancer biologist, a few weeks ago. And yeah, I mean, he fundamentally said the same thing. I mean, obviously, all his work is mitochondrial in nature, and it just looks through the lens of metabolism when talking specifically about cancer.
Right. And what a unique contrast. Now you're talking to a plastic surgeon and a, deep cancer researcher, and essentially we're going to boil down to the same foundation. That's really cool.
Yeah, no, it is, and it is what makes me grateful for my background. Granted, it's nothing like yours, but having this sort of vague idea of how biochemistry and physiology work just allows me to sort of maybe bridge these gaps and at least try and answer the odd ask the odd question that's in some way interesting. Anyway, Dr. Chesnut, I reckon we might as well deal with the elephant in the room, and that being sort of plastic surgery and aesthetic medicine. Now, it's got a certain stigma about it, and I think it's traditionally seen, and correct me if I'm wrong, and I think it's changing, as being very superficial and unnecessary outside of a reconstructive setting when someone's obviously had an accident, a car crash, and they need they need reconstructive surgery. I suppose it's a bit of a follow-up from my last question, but made you choose aesthetic medicine, just broadly speaking, as a speciality?
Yeah, it's interesting because when we train in any type of reconstructive and plastic surgery, that'd be like the broad name that encompasses whether we're talking about faces, bodies, anything like that, eyes. We start with reconstruction, and
Yeah.
the aesthetic part really comes with, in this idea of restoring form and function a little bit. And for me, it was driven a lot by this regenerative aspect of it, right?
Okay.
Because there is this superficial view of it. And I think that the cliche view of plastic surgery is that it's transformative. And this is a big delineating factor. This is a wildly important point, which is there is the transformative side of things, which is taking something that never existed and creating it, right? And that's just not the type of particular practice that I have. That would be something
Yeah.
like breast augmentation. In general, it's just making something different than it ever was before. I'm in more of a rejuvenative or regenerative side of this. So I am trying to take things back in a direction from which they came.
Yeah.
And I think that just by nature, there's a little bit of less superficiality in there. Not that
Yeah.
there's none, but it would be. I just think of it in the same way as I would that we're clearing out a coronary artery. We're taking it
Yeah.
back in the direction that it went before. Or I love this. I have this story of a patient who was married to somebody who's a really famous Major League Baseball pitcher in the United States, and her husband was one of the best ever. And as he was getting towards the end of his career, he was still a huge contributor in the league and on his team, but he had some degenerative changes in his shoulder, as we might imagine would happen with repeated use of this thing.
Yeah.
And so if we kind of subscribe to this idea of, well, just let things happen as they go and, just age naturally, him performing as the pitcher would have been, well, he's got use out of his thing, age naturally, and just kind of fade away. But he didn't want to do that. He didn't need to do that. He still could contribute, and he could take some simple steps with some regenerative medicine, which is a little bit of an application to now, not as much when this is actually happening to him, where he could have this little minor surgery that was arthroscopic, small incisions, still
Yeah.
surgery, unquestionably surgery, and he could extend his performance and his identity and his physicality for extra years and get a little bit more out of what was degenerating naturally. And so, of course, he did that and extended his career and, wasn't the best he'd ever been at that point, but still kind of extended things a little bit. And interestingly, that's a lot of what I'm doing. And if we want to, we have to really at some point accept that what we look like and put out into the world affects our performance or how we're influencing or just, our aura around us.
Yeah.
I'm just altering that a little bit. I'm not changing it. It's not dramatic. It's all these little subtle changes. And I think if my practice is built on before and after photos, and if you
Yeah.
go look at those photos and videos, I think that's why a lot of people gravitate towards me is like, can't even really tell what happened. The person just looks a little bit more vital or more refreshed afterwards. They don't look different. They don't look even necessarily like way younger. It's just a little bit of like, oh, that's a fresh look. And our external appearance wildly reflects what's happening internally. This gets to the nitty gritty, I think, of our conversation later. Is unquestionably we can look at our epigenetic markers and we can really get into predicting what somebody's going to look like just based off of what's happening internally.
Those are excellent points. And I really do sort of appreciate the fact that what you're trying to do is sort of almost reestablish the baseline rather than augment, which I suppose fundamentally is what it is. Again, I probably should have mentioned this earlier, but would you mind for the audience quickly just sort of breaking down the difference between regenerative medicine and, again, this aesthetic side? Something I should have brought up earlier, but I think it's probably quite an important point to make before we carry on any further with the conversation. Would you mind just breaking down those two terms quickly for the audience? I think I should have carried up on that earlier.
Yeah, absolutely. I'm gonna define this through the lens of what I do a little bit, where you have transformative things, right? That is taking a 20-year-old who does not like his or her nose and changing it, right? Nothing physiologically happening there, just straight transforming it into something that didn't exist, which is really common and is fine. No judgment. It just is what it is. And then we have my world, which is more anti-aging. And when I think of regenerative, I like to look at this again through my lens because you and I right now immediately could do something regenerative with little to no input, right? That could be a peptide that we take or put on. That could be a small treatment that like very simple things can be regenerative. And that is trying to harness our internal ability to repair and restore. I'm going to go with soft tissue. This could also be bone and things like that, but soft tissue being skin, muscle, fat. That's what's really important to me in our face. So just turning on mechanisms epigenetics, regulating inflammation, vascularity, whatever we need to do to make the tissues that we already have better, right? So that is just regenerative medicine in and of itself. And then in my world, when I am physically moving or replacing or adding a little bit of a mechanical force to gravity, say that would be a really common situation, now I can take that regenerative medicine and get the baseline improvement out of it and improve our healing and long-term results from these little minor procedures that we're doing. So I'm really trying to mix those things together. And that's where my world of facial plastic surgery intersects and interacts and benefits from regenerative medicine.
That's perfect. And to be honest, that lines up with my next question perfectly. Now, as any long-time listener of our audience knows, and something I've already sort of alluded to, my background is in biochem, and I've since gone down the integrative rabbit hole myself. And all I can say is that I see things again through this lens of a chemist, for better or worse. Having worked with people for a while now, I think I've come to the conclusion that maybe outside of infections, genetic issues, and a high toxic load, one of the main drivers of any sort of systemic dysfunction within the body is stress, especially psychological stress. It sounds pedestrian. I know we hear it all the time, how stress is a killer and it's making us sick. But the more I look at stress and stress physiology, the more I feel it needs to be central to any sort of health protocol. Now, bringing that full circle again, I do know, among other things, you sort of also, operate in this sort of in this functional space, as you've alluded to. Have you ever noticed that by improving an individual's appearance, you can also you can modulate or lower the stress that they are under, and by as a result see improvements in other aspects of their health? I know I'm bolting together mechanisms here, but the way I see it, I think that if somebody's experiencing feelings of inadequacy as a result of the way that they look, that's going to by default impact their health. And if you can remove that dysregulation of the central nervous system and make them feel better about themselves, I assume that there's then going to be a carryover to the rest of their health in general, how they operate, feel, etc., if there is some sort of underlying condition perhaps.
Absolutely. There's so much in there, Robert. And that's such a good question. I don't know that anybody's asked me this in that way before. And I love this because I talk about stress often and the way that it leads to aging, right? And I'm not being specific with, I'm going to just reword what you said, with the cognitive dissonance that comes with not looking the way that you want to or looking the way that you feel, right? And we know that basic stress, from all the other things in our life, kids, jobs, work, entrepreneurial things like you and I were talking about offline a little bit, definitely contribute, right? Via tons of mechanisms, epinephrine, norepinephrine, cortisol, right? But this, I'm going to skip that because you can talk about that a lot. I think the unique part here is this, like, does changing the way you look relieve some of that stress? And the answer is yes, but it's not the sole aspect of this, right? And what I mean by that is, and I don't think it's as insightfully front and center with what people think. The most common thing that I hear from a patient when I first talk to them, and I actually, secret story, love to hear this from somebody, is I just don't look the way that I feel inside. I feel so good. I feel vibrant and vital. And then I look and it just doesn't quite match up, right? And so that's a great win for me because I know what I can do objectively, right? And I want the subjective to line up. That if somebody doesn't feel good, no matter how good I make them look, I don't think I can actually turn that around. And so what I'm really doing is trying to line up their already internal identity and vision with what they kind of see in the mirror, making the objective match the subjective a little bit there. And when I do that, unquestionably, relieving that cognitive dissonance takes away some of that psychological stress that's there, right? And we know that all the ways that lines up with, inflammatory cells and IL-6 and changing steroid or cortisol receptors and their sensitivity and downregulate, all these things add up. And I think what really happens there, and this is why I like to talk about baseline stress so much, is that without the baseline stress, downregulating the cortisol receptor sensitivity in numbers, right? I don't think that little psychological stress of, not matching how you look and feel would be as impactful, right? It's when that, piggybacks on top of the baseline stress that things add up. And so part of my long-term mission, again, this is where that overlap that you're talking about with the integrative or functional medicine comes, is trying to not only relieve the cognitive dissonance of how you look and how you feel, but then also like changing the baseline, which we could argue is probably one of the most beneficial things we could do for them long term, and also preserving the results that we're getting them. And so there is a super complex interplay of chickens and eggs and what's happening where, but it all ties together unquestionably. And this gets into, I think, something we'll talk about later too, with even how we're regulating our sex hormones, and back again, everything coming back to maybe even the mitochondria in some capacity.
Yeah, well, I mean, ultimately, I suppose mitochondria help with the production of hormones and all of that. So, yeah, no, that will definitely be a discussion we'll have in a minute. Dr. Chesnut, do you, maybe a bit of an odd question, but are there ever any sort of clients that you work with specifically that are coming to you with sort of a broad spectrum of issues, that they have their aesthetic concerns, but they're then also coming to you with maybe a greater health complaint? Do you sort of work with people like that in tandem, or is it very sort of binary in the way that you do end up working with patients, with clients?
No, I like the situation where we get a more comprehensive or holistic integrative component to it, right? Because that's where we can make the most. Again, this gets to my personal goals, missions, values, and that I value that part of my life and career. I'm a very like high quality, low quantity surgeon. I'm not doing 5 surgeries a day. I'm doing like one a day with one person that I have a deep relationship with, and I want them to sort of live their best life afterwards, right? And that's where I have my little moment in the operating room, say, but then after that is where we can really have a lot of impact too. And so the most common and ideal situation for me is that we meet with somebody. They often have a baseline knowledge. Like, let's say, pretend, Robert, you're going to be a patient at some point. You have a crazy, crazy strong baseline knowledge, right? And so, great, let's take wherever you're at. I'll meet you where you're at and plug you into this sort of like forever turning wheel of like, what's your, get your genetic profile, get your metabolic profile, get your genetic and epigenetic aging, and get all the information that we can. Then we have that for the long-term span, which is, wonderful and something you talk about on here a lot. But then the unique part for me is then I can also use that information to make your surgical procedure better, make your recovery stronger, make the results last longer. So I get to kind of use the baseline knowledge that we're going to have for this like little moment in time to make it better and make it go smoother. But then we also have the longitudinal, ability to impact your overall metabolic health, longevity, health span, however we want to word it. And that is the most, like I said, the most common and my most ideal situation, because it continues the relationship. We get long-term benefit. We get to like, cliche, change lives a little bit in that way, in a way that's really positive.
Yeah, I have so much I want to ask you there, especially with regards to all the testing, because you've just lit a fire under me, and I just wanted to go in there, but we will get there.
Okay.
Okay, so I'd like to transition into talk about aging skin next, if that's okay. Now, the way I see it, which granted is fairly rudimentary, skin health or youthfulness, or maybe a combination is a combination of multiple factors, including hormonal health and function thereof, and that its effect on collagen production, all the way through to how effectively mitochondria are of course working. Of course, there's a lot of overlap there, but fundamentally, the way I view it, it's a deterioration in these various cell types and metabolic processes in the body that then drive this sort of deterioration in skin appearance. Could you elaborate on maybe what's going on in here, and I suppose why skin quality and tone deteriorate with age?
Yeah, absolutely. So skin, and this is a great place to start, because I mentioned a little bit before, like these soft tissues of skin, fat, muscle being the most important parts of facial aging, but it doesn't stop there. We talk about facial aging so much because just as I'm sitting here, the rest of me is covered and you can see my face, right? If I didn't have a shirt on or I was naked, you get to see aging everywhere, how it looks, right? And so face becomes especially important here, but face is also, because of what I just mentioned, exposed to things that the rest of our body isn't. The skin there is exposed to more UV radiation, environmental exposures, things like that. So all of these add up into what this skin aging is. It is truly the window to our internal health, no question about it. But then it also kind of has this double-edged sword, because it's really affected by what's happening internally, but also has this massive external effect, more than any other organ system does. Really, maybe our gut, you could argue, but because we have UV and environmental exposures. And so you hit on it. And I think the most important cells to talk about, the actual cells of our skin, are called keratinocytes, right? They make this protein called keratin, which is our hair and our nails and the barrier of our skin. But then we also really need to focus on a cell called the fibroblast. And fibroblasts become really important because we know that their mitochondrial health is wildly important to creating the things you hinted at. Let's talk about collagen and elastin. Collagen's the hot one. Everybody talks about that. Collagen's the structural strength of our skin. It is important, but in my opinion, is less important when we talk about aging changes or things we recognize than something like elastin, which is a much more delicate flower when we get into these little skin fibrils that kind of hold things together. Elastin is elastic, as the name would suggest. It controls how our skin recoils after a force is applied to it, and it's wildly sensitive to damage from external exposures, UV radiation. It breaks down easily, and it's hard to rebuild, right? This is where regenerative medicine really comes in, hinting ahead, because we want to rebuild that elastin tissue, and there's good ways to do that. But then these fibroblasts also make things in our extracellular matrix, like we've probably heard of hyaluronic acid, which attracts water and things like that. So when we get into our skin aging, it reflects what's happening externally, which I've talked about a lot, but it also reflects a lot of what's happening internally with our internal metabolic health, which meets in the mitochondria, goes to those fibroblasts. How well can they make collagen and elastin and hyaluronic acid and these very high demand, to turn on the DNA to make those happen takes a lot of energy. And so fibroblast is a very high energy cell, and it needs its mitochondria to function well. So when we have any dysfunction there, metabolically, our skin is going to reflect that. And this comes with metabolic health. This comes with hormonal health. This comes with external exposures. And our skin is that window, basically.
Yeah, I'd love to take a deeper dive into the hormonal side of it in a second, but just a question just jumped to mind. What do you think about collagen supplementation in general? I mean, there's a lot of back and forth on that. I mean, a lot of people will just point to the fact that you're just ingesting your amino acids, your hydroxyproline, proline, etc., and that those are then forming the base amino acid profile of the skin. Whereas other people, and granted, well, not people, but companies and studies, will often point to the fact that collagen peptides have an immunomodulatory effect, and in doing so can actually alter the way things like fibroblasts are going to function. Do you think collagen peptides are effective, or is it really just a glorified amino acid supplement that's helping to provide the raw building blocks for the skin in general?
Such a deep, good question. In a nutshell, to answer this in one sentence, is I would say it's a neutral to a positive, right? And there's the one extreme that is when you digest any protein, you're breaking it down to its, amino acids, essentially individual amino acids. There may be some differences to that, but they're transporting across the gut barrier, then they're getting reassembled, right? And from that end, collagen is a protein. It's missing tryptophan. It's not a complete protein, but it's still a protein, right? And you have some nice essential amino acids in there. So that would be the one school of thought that is you eat it, you break it down, and then you got to reassemble it. And then I think that the other extreme that a lot of people think and want to believe is that you eat collagen, it crosses across your gut intact and just goes to your skin, and all of a sudden, wow, my collagen. Yes, exactly. Which we know that's not true either. And like many things in life, there's something more complex happening in the middle. Whenever there's two extremes, usually we look in the middle for the actual truth, right? Yeah. And we've been trying to figure this out because you can't argue with those data too much that are showing that taking collagen improves your skin health. There is evidence to show that. Nothing is negative. There's some, unequivocal neutral studies, and there's some positive studies that show it, right? And this is what the companies want to sort of hang their hat on. And you touched on this like little immunomodulatory part of it within the fibroblasts. And that may be what this missing link has been, is that, okay, well, we know that we probably are breaking it down to some degree, but then something's happening with the fibroblasts themselves. And, again, so I subscribe to this idea that definitely isn't going to hurt. Don't spend your life savings on it because it's not something worth hanging your hat on, but you're at least getting a high quality protein minus one amino acid that's essential, and you're likely having some small benefit to your skin overall, especially when you're pairing it with other things that would increase collagen production, because if you're increasing collagen production, you need the amino acids to make that happen. And that could be, getting into red light therapy or anything like that later on too. So again, neutral to a positive, don't break the bank, in my opinion, but it's likely to either do nothing, worst case, or have some small benefit.
Yeah, no, I agree. I think the only caveat to that would be anyone who's taking collagen to support muscle growth. I think that's really sort of probably pushing the boundaries of what's sort of acceptable. I mean, just the leucine content there being so low, and
Right.
you're not going to trigger mTOR and actually support muscle growth in any way, shape, or form. I think, and there are definitely companies out there that are promoting specific collagen products as being supportive of muscle growth. But outside of that, I agree with everything that you've just said. I'd love to come back to talk about the hormonal side of it for a minute. Now, this is obviously going to affect any aging individual, but specifically women, people who start, individuals who start to go through menopause, where they get this sharp drop off in estrogen. And now estrogen is obviously very closely linked to the production of collagen. So I suppose this is very much in the sort of regenerative wheelhouse. But are you sort of looking at sort of when you're sort of working with a client, specifically a woman, but I suppose to an extent an aging male as well, when you're going to get this drop off in testosterone, because obviously testosterone converts into estrogen to some extent. Does the HRT sort of conversation come up regularly when you're working with somebody to help them sort of maintain the health of their skin?
Absolutely. And so absolutely, yes, it does. And I'm also going to use this at the end to segue into a small conversation on topical or like products to put on, which is a conversation I actually don't love having because most things are snake oil and not helpful. But I think this whole thing illustrates some important points. And our hormonal levels, and specifically our sex hormone, like our sterol levels, are wildly important. Estrogen being the main one, but testosterone, progesterone also play into it. Estrogen is the wildly important one for skin, functioning as a true hormone, crossing into the nucleus of these fibroblasts and changing the DNA regulation to make more collagen and elastin. And that absolutely happens. And when levels decline in menopause, coincidentally is right around the, not coincidentally, but is right around the average age that I see somebody for the first time, usually, kind of like as they change, which makes sense, right? There's aging is nonlinear for sure. And this is probably the steepest decline that we have is right around this time. For females specifically in menopause, but like you're saying, it happens with men as well. And so as we have a decrease in our sex hormone levels, specifically estrogen in our fibroblasts, and in our adipocytes, in our fat cells, we drastically change the skin everywhere. And in our face, the fat pads of our face change quite dramatically around this time. And doing something like HRT is a conversation that I have that is, I'm not advocating to do HRT solely for a facial aging standpoint, but again, this is just a reflection of our internal health, right? So this is not just happening here. And so I am generally encouraging somebody, I have a team of for functional medicine within my practice, and whether they're doing it with us or with wherever they live, it's a conversation worth having going into a procedure, and most importantly, long-term afterwards, for keeping and maintaining it if it fits in with their overall health goals, longevity goals, and sort of their lifespan and health span goals. It is important. And the best illustration of this, I think, this is my little switch over to talking about topicals, right? Which is, again, I don't love topicals. I don't talk about them a lot. I'm not a big fan of most of them. But something like a retinoid, a vitamin A derivative, right? Vitamin A is a fat-soluble vitamin. And in the sense of our skin aging, we've all heard of retinols, I think, for skin aging. It functions as a hormone. And so it hits this star protein, this steroidogenic, acute regulator protein. That's kind of what the star protein, but it's an excellent example of when that little steroidogenic, like, again, sex hormone mimicker, when the vitamin A goes into the nucleus, because it's fat soluble, it can go in the nucleus, it can upregulate, it sort of replaces what estrogen is doing in aging skin, right? So it's a nice little hack, if you will, to get around decreasing estrogen levels, which happens anyway, to turn on some of those genes that upregulate collagen and elastin. And so when I get the question all the time, what are your favorite topicals? Like, kind of the main one I would point at is a retinol. Cheap, available, easy, low risk, and beneficial for dang near everybody who's having any sort of skin aging happening. And so it fits into that really well, but it illustrates what's happening in our skin as those sex hormone levels decline a little bit. It does a really good job of replacing or working around that.
Yeah. And am I correct in saying that it's increasing the turnover of the skin cells within the fibroblasts? Is that sort of mechanistically how it's working? Is that vaguely correct, or am
Yeah, so there's two aspects to how hormones change what's happening in our skin aging. And turnover is one thing. Turnover is a really big conversation as we talk about thyroid hormone, interestingly.
next question.
Okay, yeah, so that segues well into that. So there's the turnover question, and then there is the creation of these skin fibrils or these glycosaminoglycans, the extracellular things that support our skin as well. And the sex hormones drive more of that production: collagen, elastin, hyaluronic acids, things like that. And they regulate those to make our skin strong and elastic, or to make like I said, I kind of hinted at the fat cells of our face, to make those strong, structural, and voluminous, right? If you can imagine, the fat pads of our face are meant to create shape and structure. And if they get weak, we lose shape, structure, and volume, right? But then we get into cellular turnover, and that is where something like thyroid hormone, specifically our skin cells have a receptor for T3, and that is a wild regulator of the cellular turnover. And so it does a great job of illustrating how important that is, because even in normal-ish ranges, lower T3 levels that would be considered normal can have impacts on our skin aging by changing the turnover. And that isn't just our skin, it's our hair, it can be our nails. People that have truly low thyroid hormone levels know that everything loses luster a little bit over time, right? Because the turnover time for, kind of going through all the layers of our skin changes from a month or something to 2 or 3 months. It goes doubles or triples. And so that turnover rate is really, really important. So thyroid hormone really, really drives the turnover rate. It also controls the creation of some of the extracellular matrix, like, for example, really low thyroid hormone over time. We overcreate hyaluronic acid in our skin, which looks really bad. It's called myxedema, and it kind of it creates this sort of like overly puffed skin look a little bit, which sounds like it might be good, but looks really unnatural, and is a little hint over to these ideas of dermal fillers that people use and kind of overuse to anti-age early on. Creates kind of a funny look over time. They start to get puffy and inflated. Well, that gets mimicked with thyroid hormone levels when they're low, and it's related to that turnover. On the flip side, the retinols can, again, help increase the cellular turnover rate too. So we have double benefit there. Not only are they just improving the creation of fibrils, but they, like collagen and elastin, but they're also changing the cellular turnover rate. So there is this overlap or interplay of what's happening between the sex hormones and something like thyroid hormone.
Okay, that's perfect. Again, probably a bit off script. Have you ever looked at the use of topical thyroid creams at all? I know they exist, but I
Yeah,
know that.
they exist and they've been looked at, and they do have some effect on skin health for sure. And I think that they've been under talked about, or we don't talk about them as much in overall health, because if you're needing them topically on your skin, there's probably, again, thinking that all tissues have the same exposure, that there's probably more of a systemic issue. The same thing goes for estrogen creams, actually, which we know can work as a systemic absorption, but looking at those specifically as skin health, they have similar benefits. But then we get into what's happening with our overall systemic health and those sex hormone or thyroid hormone levels from an overall systemic standpoint. So yes, there certainly are topical versions of them, but they generally get more applied to an overall use.
Fair enough. I'd, I suppose I'd love to sort of start talking about your specific process and the testing and everything that you do up front. But before we get there, the longevity side of the equation, specifically with regarding how you start to look at an individual's mitochondrial health from a sort of regenerative standpoint. What are your sort of go-to therapies, or how do you sort of educate people with regards to this sort of health span longevity side of the equation? Are you a fan? Do you sort of take people through a sort of a dietary education side of things, or are you a proponent of NAD supplementation products like that to support mitochondrial health in general? Again, coming back to the from this regenerative standpoint.
Yeah, so I try to tailor this with my patients to where their interest levels are going to lie and where what they can like I would say commit to, or kind of what they know they'll actually do, because we could go crazy with this, and then if there's no adherence it doesn't matter. And so again, a lot of people that I'm seeing for the first time have a baseline that they're doing really well with. And so rarely are we starting at ground zero. It would be honestly kind of really fun to have that situation where it's just like educating from the ground up, but everybody comes in pretty strong with where their baseline is. And so, again, focusing on the surgical portions of my practice, I am often working with them from a nutritional standpoint on like a fasting protocol, doing more like anti-inflammatory types of things, which could be anything from looking at the types of fats they're eating to, what their gut health is, right? And so this is where it gets very individualized into like, as any, I think, integrative or functional medicine practitioner would do. And again, I'm not physically actually doing this myself. It's like this connection. And then it's like, I would with that information, I'm like, okay, great, let's chat with our team. Because sometimes people are doing this at home, they're not doing it with us necessarily. But I'm, just kind of guiding whether it's their functional medicine provider at home or somebody in our practice, like what we want to be looking at going and what kind of information I want, and sort of what types of things. So I love it when I have patients on like let's call it a month before their procedure, we start lowering their systemic inflammation very purposefully. We start to go on some fasting protocols or fast mimicking even types of protocols, to get them in a position coming into surgery where they're already in sort of a regenerative state. They're mobilizing their stem cells. Their sort of metabolic health or their mitochondrial health is as optimized as it can be. And again, this is like going back to this mindset of an athlete, right? If Ronaldo was going to have a knee injury on a set date, we know it's coming. It's going to be like Thanksgiving or Christmas Day or something. I don't know, whatever. We know that this injury is coming. Leading into that known injury for this athlete would be a whole bunch of prep. Getting them ready, knowing like, okay, before this injury happens, let's make sure that you're ready to recover before it even
Prehab,
goes
yeah.
down. Yep. And so I'm doing the same thing, less physically from like, we're not talking about a knee injury here, but from a physiologic metabolic profile, I'm just trying to get as much time with them going into it. And again, it can be some people are really willing to dive deep and have these big changes, and that's the best case scenario long term, not just for our procedure. But then, others, it's more just like, okay, let's educate you about an anti-inflammatory diet and fasting and kind of getting things set just in that like little month, or few weeks leading into their procedure with me.
That's perfect. And what sort of information do you ideally like to see beforehand? We mentioned this a bit earlier, sort of the genetic testing specifically, but are you looking at any more sort of detailed blood work or specific or anything in that respect, or you've already mentioned gut health. Are you doing any sort of organic amino acids testing, GI map stuff like that to sort of get this with your team, of course, to get this baseline assessment up front? I suppose what I'm asking is, what sort of data do you really want to see in a patient before they, I suppose, go under the knife?
Yeah. So if we have their genetic profile, that's great because we could open up a whole world of things that we'll find within their genetic profile. So I love having that information, and that's great. Again, from another long term, definitely systemic blood work. That is the universal sort of layover that comes. Everybody has their blood work before surgery, and that's the sort of easiest thing for them to do at home. We'll sort of dictate what we want, and I'm looking at again comprehensively at that. But let's go back to our discussion before about stress. I'm not getting direct cortisol levels, but I can even see things like their CRP. Like what's happening with their inflammaging. They're just like baseline inflammation. And that's wildly important information for me going into the procedure itself, because that would be like a red flag, glaring at us as something that we need to be able to go after. And when we start pairing, of course, their lab work with their metabolic profile, it even helps me design things like their post-operative IV therapy as to, oh, great, let's talk about any nutritional deficiencies they might have if we have that information, or how they methylate, or all the like kind of catchy things that that we see often actually. And so they can take it home with them afterwards as far as like knowing it long term, but I can also make that recovery better. The fun thing to also get is if I can get somebody's metabolic and genetic aging, again, looking at their epigenetics, that's a really cool, insightful piece of information for somebody to look at coming in, because like many things, it's like you weighed yourself for the first time and you have this baseline, like, oh, great, how is this going to change over time, and what can we do? And I think, Robert, going a little bit full circle, we can circle that back to one of your original questions is, can the procedure itself change what's happening with, say, maybe their epigenetics
Epigenetically, yeah.
afterwards? Yeah. And so, still to be determined there as we get, kind of collect more information with that. But that's something I'm super curious about and paying really close attention to, especially as we can get subsequent, follow up epigenetics on people.
Yeah, you obviously are a fan of epigenetic testing, and I've had a couple of chats with Dr. Matt Dawson from True Edge Diagnostic.
Yeah,
I'm still back and forth regarding the validity of the testing. I must admit,
sure.
um, I've seen more than one provider do the old trick where they've sent in the same sample on the same day. They've just submitted two samples and they've got completely different test results back. Have you, what,
I've had that happen. It's very, very similar. Yeah, absolutely aberrant outliers. And I totally agree. And and that's why I view that as more of almost like a fun part of this, more than like this essential aspect. And it again, going back to like weighing yourself for the first time, is weighing yourself actually important? Does it truly reflect your health? No, not necessarily, right? But it's a piece of information that we can like talk about, look at, and there, again, different parts of it have different validity, no question about it. I completely agree with that. But it gives us at least some metric to follow based on. I've experienced this personally where I've had, close together tests that were drastically different from one another, and like, well, nothing changed that much. But as we sort of get back on track, we can kind of follow a little bit of a baseline, and it's interesting though, because I do agree with that completely.
Yeah, no, I think it's interesting data, and I think that it just needs to evolve. I think there have to be bigger populations that need to be assessed, and the data then cross-referenced against to sort of get a true representation of what these values actually mean. And then can they actually at the same time be like sort of cross-referenced against more traditional lab values, potentially, where there is already that large sort of depth of population data that sort of speaks to their specificity and validity. But yeah, I think it is, as you said, interesting data, and I think all data fundamentally helps at the end of the day. Dr. Chesnut, I'd love to talk about your post-operative process, if that's okay, something you've already alluded to yourself. Now, I suppose fundamentally it's probably one of your main USPs, one might say, and that is what separates you from the rest of the industry. Now, I believe you use a lot of HBOT and red light, but I'd be curious to find out what other sorts of biohacks, and I hate that word, or
Yeah, right.
technologies that you're using to help speed up the healing process. Fundamentally, what does your post-operative process look like?
Yeah, so it's interesting because I break this up, if I'm being like full transparency, I have an entire protocol I go through, and I even think of it through like levels of evidence for myself, right? What are the like slam dunk, unquestionable, massive benefits? What things are we doing that maybe have like some data, but it's not as strong? Those data aren't as strong as, what other things would be. And the the anchor of that protocol for me is HBOT. And hyperbaric oxygen therapy has approvals from the US FDA for specific types of wound healing and basically helping tissue repair itself. We know that that works well. And it's interesting because that's not readily adopted across every specialty in medicine. And to me, it is the most powerful, anecdotally, from what I see in my patients every single day, and has the strongest evidence behind it. But in a specialty like, say, orthopedics, they're not utilizing it as much, which is very interesting because they could wildly benefit from it. And so that is the anchor, the mainstay. If I could only choose one, that would be the one. I'm seeing the frequency of that increase so dramatically from when I started my protocol, and as it's developed over the years, it went from being a complete unicorn type of a situation to, especially with hopefully me helping influence and educate, like a lot of my colleagues are now sort of like at least doing that one thing, which is great, and it's improving patient care and outcomes and recovery time and long-term results, which is really cool because patients want to get better faster. That's their main driver afterwards, which is great because it achieves that for them. It helps their inflammation swelling pretty dramatically in the first week or two after the procedure. I'm a bit obsessive and interested in the long-term results of my work, right? I want my masterpieces to be great forever. And so it's a great benefit there too, because very uniquely, it improves the long-term results that we're achieving. Let's say something like fat transfer, which we haven't really talked about much, but in almost every procedure that I'm doing with the little procedures or surgeries, I'm borrowing some of the patient's adipocytes or their fat-based stem cells or, fat-derived mesenchymal stem cells, and I'm using them in their facial tissues, in the fat pads in the skin and the muscles, things like that, to help them regenerate, add volume, different purposes for different types of fat. But that's now what we'd call a graft. It's a free fat cell disconnected from its blood supply, moved to a new location, has to set up a new blood supply. That's a difficult, arduous, stressful process. And that's why we want stem cells, because stem cells get turned on by the stress. They make new blood vessels, they help the inflammation. And the hyperbaric oxygen therapy helps those cells do that work, basically, by supporting them in their, sort of oxidative stress environment that they're in. And so it's a long-winded way of saying something like fat transfer has better results when we're using it with hyperbaric oxygen therapy. So now we've improved their long-term results with something that also makes their recovery better. So there's a ton of fun physiology around hyperbarics, but that's the mainstay, the one that I think if any surgeons or other practitioners or anything, patients are listening to this, like if you ever have a surgery, find a hyperbaric chamber before you go so that you know where to go afterwards, because that's the one thing that unquestionably will benefit your surgery, right? Another high level of evidence, switching gears from hyperbarics, would be something like pulsed electromagnetic fields, PEMF, which again we hear about, and there's all kinds of different, ways to get that with mats. But pulsed electromagnetic fields also has strong evidence backing it up that it improves healing. Its strongest evidence is actually in bone healing, which is really hard to heal, in non-union and malunion of bones, right? And it works by creating extracellular matrix and promoting migration and healing. And so it's great. There is evidence in my world in plastic surgery of it helping to heal difficult wounds as well. And when we use it in, and that's all like these crazy situations that are like, last resorts. We need help with this bad situation. I'm not in bad situations. I'm in good situations with healthy people having elective surgery. But this is where we have to extrapolate mechanisms and know that the same things it's doing to improve the wound healing in those difficult situations, it's helping to do in a more normal acute setting, make them happen faster, make them happen better. So pulsed electromagnetic fields is something that I also use a lot of. Red light therapy, switching gears from hyperbarics, PMF to red light, another strong evidence, right? Wound healing, skin health. That one maybe has the most kind of broadly scattered data across all kinds of different uses, if you will, and all of them kind of come back again to meet in the mitochondria and help the healing process. So there's infrared, there's near infrared, there's red light, there's all the aspects that go into it. But with what I'm doing, we have benefit across all of those because the longer wavelengths of the infrared penetrate to fat pads. Those are healing. The shorter wavelengths of like visible red light are hitting the skin surface. Well, I'm often doing something to the skin surface, like a laser or using those stem cells on the skin surface to help that regenerate. So we're supporting all of those different sort of quite literally three-dimensional depths of healing that are happening with something like a red light therapy. So really high evidence, again, same thing, like so simple and basic to use. People can have this in their home and get long-term benefit from it and then also have it for healing. So that's probably the first one I would say of anybody listening who's having surgery for any reason. You're probably not going to have a hyperbaric chamber at home. You totally could, and there's benefit to that, but that's a high expenditure. Same with the PEMF mat. But something like a red light, wide applicability, not overly expensive, something you could have at home and apply to your actual surgical recovery at home. And it's a really great option. I'm also using, like I was talking about, targeted IV nutrition as part of, my healing. And that's, unquestionable. Like we know that our baseline nutritional status is supporting that. And it's interesting for me in that my patients, and anytime somebody has anesthesia, they would fast before that, so they're coming off of generally a day of fasting. And we're supporting their hydration levels and things like that. But one of the most interesting things I find with that is, let's say it's post-operative day one, the day after surgery, and they get their nutritional IV that's customized to them, has amino acids. I do use NAD in that.
I have
And
thoughts on that.
yeah, and
Uh,
that's in the beginning of the
yeah.
post-operative period. Um, and they just feel wildly better after having, so there's this like subjective how they're feeling afterwards, and then there's the physiology of that, how those are interacting with their actual healing and inflammatory processes. Yeah, you were going to ask a question about that.
Yeah, and I was just going to ask a question about the NAD. I mean, the way I view it, NAD is an intracellular coenzyme. It's supposed to exist obviously within the cell. The moment you sort of introduce it intravenously, it's now an extracellular substance. It's floating around the bloodstream, and in doing so, I sort of working through some of the biochemistry and literature. I reckon that that's actually creating enough sort of extracellular what's the term? It's upregulating enough oxidative stress potentially to drive the cells into this cell danger response, which is oftentimes triggered by high levels of extracellular ATP. So I don't know if I'm completely a fan of, just personally, of course, sort of extracellular NAD. I like the idea excuse me, intravenously prescribed NAD. I like the idea of sort of taking it sort of orally, and then obviously letting that sort of get into the bloodstream, into the cell, as it would do normally, as if you were taking any sort of nice and derived compound, be it NR, NMN, etc. Do you think there's any sort of rhyme or reason or logic to that? Or, I mean, I
Yeah,
know
it's
it's,
interesting. I mean, this is it's a super deep thought and interesting conversation about. I think my head goes to a bunch of different places, and I'm thinking on the fly with you here a little bit, being in that, um, like getting an NAD drip just in a healthy, like post workout state or something, is on the spectrum to what I'm doing, which is like now we're in a highly regenerative systemic injury. Like your entire system is revved up healing from the surgical procedure, right? So my head goes to like, well, I wonder if that changes the way that we have utilization of that NAD, for better or for worse, right? Because you're saying if it's triggering an extracellular stress response in a system that's already stressed. I do think that the NAD in there is one thing. If I could, like, this isn't a question you've presented to me, but if I could crystal ball of things that we will know more about or do differently maybe in the coming years, I think that the use of NAD is going to be one of those. And I wouldn't be surprised in any direction that it goes in. If it's like, going more towards the oral form that you're speaking about, I don't think I would be terribly surprised if that's the way we gravitate. But I also wouldn't be if we start to figure out that, like, well, there is actually great uptake from a IV type of exposure, especially, again, this is where my head goes in my world, in the system that is sort of stressed and metabolically stressed already in this healing state. Yeah.
yeah, no, the data will obviously sort of show us what happens in the next couple of years for sure. What about cold? Now, I don't imagine anyone's going to get into a cold tub or morozko straight after surgery, but this, but this idea of cold being, well, just healing in general, you're going to sort of lower all these inflammatory processes. Now, obviously, you don't want to do that sort of day one post-operatively, because you need a certain amount of inflammation for healing to occur. But what do you think of tools, maybe like cryotherapy, where there isn't this sort of risk of sort of slipping your ice tub and then needing an orthopedic surgeon, but utilizing that as a tool to sort of, yeah, just augment, speed up the healing process?
Yeah, you nailed that. So, that's a great question too. I Earlier in my career and in my recovery protocol evolution, I used cryotherapy more, again, for the same reasons, like, someone's post-surgical, and again, they're post-surgical in their face, not their body. But you're right, it's difficult to get in your Morozko. I love my Morozko. I use it personally for performance and things like that. So I have both a cold tub and cryotherapy. And so I used cryotherapy more earlier in, and I used a cryotherapy specifically that didn't expose the face. And I used it towards the end of the week that they were with me, right? And followed along, and these are patients who are often not cold naive. That's one of the more common. When can I get back in my ice bath, or when can I get back in my sauna post-operatively? And I definitely went with the idea that you just nailed, which is I don't want to stop or inhibit inflammation, right? Initially, I want to modulate it, make it more efficient. I want it to be bright, be brief, and be gone. I want to do its job really well, then go away. And we can only decouple that so much. We have to have inflammation. It takes a long time to make elastin and collagen tissue. It literally gets laid down one way, type 3 collagen, and then it gets remodeled into type 1 collagen. That's like how our wounds heal. You cannot dysregulate or decouple that or hack around that, if you will. It's got to go through the process. We just want to make it fast and efficient. And so because of that, that was a long-winded way of saying I actually stopped the more initial exposure to cold therapy, understanding it's a little bit different than like when we talk about cold after a workout, when we're talking about, hypertrophying muscle, say. This is a whole different process with a much longer lag time of sort of our wound healing. So I actually quit using cold purposefully in that period for that reason, because I didn't want to dysregulate the early phases of switching from the inflammatory to the regenerative phases of our wound healing. So a long-winded answer of saying, actually, I love cold in general, but I'm not using it early on in the healing process because I don't want to dysregulate the normal phases of our wound healing that are happening.
Yeah, there's that whole immunological process. I think it's an M1 to M2 macrophage shift, but
Right, exactly.
I think my immunology is a bit rusty. Okay, last question here, Dr. Chesnut, if that's okay, and that would be peptides. Now, obviously you're a fan of these, and I think they tend to be hit and miss depending on an individual's genetics and their baseline immunological activity as well. Of course, they're the usual suspects like GHK copper TB4, BPC 157. But what are you a fan of? What do you use in your practice, both in terms of the sort of the post-operative side of things, and then also in terms of the, I suppose, the regenerative, the products that you would recommend that people use sort of on the daily to help them sort of maybe maintain where they're at or see some level of improvement without necessarily having a full procedure done?
Yeah. So you kind of like you nailed the main ones that I use on the regular basis, which is the easy ones that have different benefits for different reasons. And this is, I think, an interesting conversation where in the post-operative period, some of the benefits of those are magnified, actually. And so GHK copper is a really small, it's like 3 amino acids, right? Very, very small. And it does really well topically. So fantastic. We can get topical application to our skin. It's incredibly unique in what it does. It's so cool in the way that it mimics, it like sends a signal of collagen injury to our fibroblasts to like upregulate collagen production, which is incredibly unique. And then it changes the way that these little breakdown enzymes called matrix metalloproteases work, and then they're inhibitors. And so it has this complex way of upregulating collagen, and then again, very importantly, elastin. Elastin. It upregulates both of those production.
I didn't know that.
Inhibits their breakdown. There's a bunch of these little elastin precursors, and topical GHK copper has like unquestionable evidence of upregulating those. Interestingly, so does taking your own fat-based stem cells and injecting them into your skin.
PRP.
If I just take your stem cells, put them in your skin.
Blood. Sorry, wrong thing.
Oh yeah. These are from your fat. So adipocyte-derived mesenchymal stem cells. The more sun damage the skin is, the better it works too, which is even cooler. And it has a lot to do with the way that it recycles elastin, basically, because when elastin breaks down, it forms these little like balls under our skin and sort of the deeper layers called the dermis that just kind of sit there. And it actually, if you've ever seen somebody who's really, really sun damaged and they have this like pebbly gray look to their skin, you'll see it now that I've pointed it out. Your reticular activating system will pick it up, but that is broken down. That's broken down elastin. And so anyway, we want to recycle that. GHK copper does that really well. It works topically. I have had patients who are really into peptides who use it as an injection as well. Using an injection is really interesting because it's cleared out so fast.
Stings like hell.
Right, yeah. And so I've had people who inject themselves, a dozen times a day to try to keep the levels up, or people who use an insulin pump to
Good
put it in.
grief.
So getting really extreme in my peptide folks
Okay,
who really
that's a
like
new one.
those. But topically, it works really well. And that would be getting into topical products, which again, I don't love. Strong evidence to back that up. I would say if I were to just like gun to my head, tell me the topical products you like, I'm generally going to tell somebody to take a retinol, like I was talking about before, vitamin A derivative, and then a topical antioxidant because it's simple, it's cheap, it's inexpensive, they're readily available, that are not going to hurt. If it's a stabilized one, it will help to some degree. But GHK copper probably outperforms what a topical retinol does when used what a topical, I misspoke there. Not what a topical retinol does, but what a topical antioxidant like vitamin C does. If you compare that to GHK copper, the GHK copper is probably better topically. So that's about as much as I'll ever say about, cosmeceutical products, because I think most of them are garbage, but that's a great use for GHK copper. So that's a regular. On the next level, when we get into thymosin beta 4 or TB500, the synthetic form of it. I like to think of the mechanisms of what I'm doing there. So that is a great, like when we get into that, I'm going to just jump ahead to VPC 157 as well. Both of these have important aspects of creating new blood vessels and modulating inflammation. And they both do it a little bit different in a little bit of a different way. But you can imagine that, VPC 157 being used a lot for orthopedic applications, tendon injuries, and things like that. Wild benefits for your skin health and your healing. Now when you've had an injury, right? You've had a surgery and you're recovering, you have a ton of inflammation going on. We want to modulate that inflammation. I even spoke briefly about creating new blood vessels that your
Yeah,
stem cells help to do,
angiogenesis.
angiogenesis, right? That now we've got two things that are helping to modulate and create new blood vessels and get through our inflammatory phases of healing and get us into, kind of those deeper, again, I'm just trying to like move that ball down the road more quickly. They're really, really beneficial for that. So those are definitely staples for me. There are oral forms with less bioavailability, right? So you have injectable is better, no question about it. But then not everybody wants to inject themselves. They can't get over that hump. There's something about it that, just kind of crosses a line for them. And I understand that. And so we make that available. If they're willing to do that, great. We're going to get better efficacy. Let's do that. If they're sort of like, I don't know if I'm really into that, then I'll have them take it orally. The other part of this is I have them do this for months after surgery, right? So now you're committing to injecting yourself for months versus taking the somewhat bioavailable oral forms. And so I'm mixed on what I'll do there. I kind of like play that again. These are individual deep relationships for me. We get into sort of what's going to work best for them in the long term, and some of them will convert. They'll start oral and go to injectable, or they'll start injectable and go to oral. But those are my staples of the ones that I like. I do have patients who come into me. I don't start them on this necessarily on growth hormone or on a growth hormone secrenolog or analog or excuse me. And I do. Again, I'm not pushing, encouraging it as much as I'm just sort of,
Polypharmacy.
yeah, and I just get to be part of observing what happens in those folks when they are already on it or already doing that before they come in. And it's great, actually. They heal fast, as you might imagine. They get great sleep after procedures, which we haven't really talked about, but I get really into the neuroinflammatory parts of my procedures as well when I talk about anesthesia, and which gets into inflammation as well, but anesthesia and sleep. And so I want low neural inflammation. So I choose my agents very carefully, and I want people to sleep really well afterwards because we know that that's going to help their entire regenerative process. And so the patients that come in on growth hormone or on secretalog or an analog do well with those phases afterwards. So I think that's just an interesting, worth mentioning for somebody who is having surgery and may already be on those things that they're going to see some benefit as well. I don't necessarily start it just for that though.
Yeah, fair enough. Two questions, and I'd sort of love to jump into the anesthesia discussion for 1 minute, if that's okay.
Sure.
On the BPC side of things, the oral, are you using the standard hydrochloride? Are you using the arginine salt, number one? And then number two, just what do you think about, obviously, as someone ages, they are going to be producing less and less growth hormone by default. So there is a point where maybe a secretagogue isn't going to be as effective as, say, just straight growth hormone or HGH.
Correct.
Do you sort of, I suppose, well, two-part question, but which salt are you using on the BPC side? And then do you think there's any point to maybe running straight GH over secretagogue?
So the arginine salt for the BPC question, and the so again, getting into the growth hormone, which is something I truly, to some degree, again, I want the best for my patients long term. I want them to have a great health span, lifespan, and I want to be part of that journey. But I don't want to impact it to that degree of like starting them on it, right? So, but you hit this because I mentioned earlier briefly in passing, and it brings it back. And like, the average age of someone that I'm seeing is like, let's just call it early 50s, right? So you're right, that secretagogue may not work that well if somebody's getting in 50s into their 60s. And so those are the patients that I do usually see who are coming to me on actual growth hormone. And anecdotally, they do really, really well. And they're, especially the first 3 months of their recovery phase where things are the most active, they definitely get ahead of the curve in that way.
Fair enough.
So, yeah.
And then just going back to that, thank you for that, by the way. And then this is definitely outside of my wheelhouse. I mean, full disclosure, most of my sort of postgrad work was looking at the glutamate receptor and the NMDA receptor, and subsequently some research into ketamine. How do you, and I bring this up because you were talking about sort of neural inflammation, etc., and such earlier. What do you think of ketamine potentially as an anesthesia or a compound, well, an anesthetic compound? Obviously, it's going to antagonize the NMDA receptor and and act as a sort of a dissociative compound, and in doing so help an individual get into a more parasympathetic or rest and digest state. Do you, well, I suppose I should just ask the question outright. Do you ever use ketamine in your procedures, or do you find that there's any value to something like that? Or is it playing with fire a bit, do you think?
No, I use ketamine in every procedure that I do. And ketamine is unique, and you just described its mechanism of action very well. And when I'm thinking about, I'm going to take one step back into why I choose what I choose. And this will resonate, I think, with everybody, which is after anesthesia, it's very typical to have this sort of like brain fog. It's when we get into medicine, we call it POCD, post-operative cognitive dysfunction, which is no joke, right? It's everybody's witnessed it, experienced it. We've all heard stories, or a lot of people have heard stories about, grandma had surgery and she sort of never cognitively recovered afterwards. Well, that's because that it's all caused by neuroinflammation, like inflammation in our brain, and we're eating into our reserves. Robert, if you and I have anesthesia that causes a bunch of neuroinflammation, we will recover. It'll take a little while, but we'll recover. But we will have eaten into our reserves in the process of doing that, right? Certain drugs, certain anesthetics are more notorious or cause more neuroinflammation, or extrapolating to POCD. More, it gets caused by certain drugs more. Ketamine, getting back to your question now, is a great agent it has a bimodal way that it affects inflammation in our brain, and at sort of like, let's just call it lower doses, does a really good job of neuroregeneration and regulating neuroinflammation, keeping it low, right? As you get to higher doses, that switches a little bit. So ketamine is an adjunctive agent that I use every single case to help in low doses, to help with the dissociation, all the things you talked about, but also regulate their neuroinflammation and sort of their neuroplasticity almost in a way afterwards, in a positive way, right? So that opens a whole can of worms with all the other uses for ketamine, but I use it in every case for that reason, right? The other anesthetic agents that I'm choosing, I don't do general anesthesia for my procedures very much on purpose. This is an elective cosmetic procedure. I do not want to cause any long-term cognitive dysfunction for something that we're choosing to do. So I choose my agents very carefully. So I don't use the inhalational types of medications that are really common for that. I don't use any benzodiazepines, which are really notorious to kind of like push people into that cognitive decline. And I don't use opioids or narcotics. And so it's a challenge. Excuse me. It's a challenge to do anesthesia without those, because those are the staples. Most of the time, I was going to say, most of the time when someone goes to just have a little short procedure, they'll usually get an opioid and a benzodiazepine. That's like the combo, the magic combo that they get for everybody. And it works for the purposes of this procedure, but then has those long-term things that I don't like. So I'll choose medications that are like central alpha agonists that kind of like slow us down. Like you just mentioned parasympathetic, right? We'd really want to push us into a parasympathetic state. Those are really great from an anesthesia standpoint at controlling stimulations, levels of consciousness, and things like that. They really prime us for good sleep afterwards as well, which is a total side benefit. And then with that, I'm using really delicate and intricate local anesthesia to minimize any pain input, right? So if we can keep somebody sort of like just, let's say, comfortable enough in their stimulation status and then have no pain input, it's a really simple type of anesthesia for them because there's nothing stimulating them. They're not feeling anything. And then they're in this nice little sort of like sleep-like state from the anesthesia that we're choosing. And then they wake up, they're clear, things go away quickly. They don't have any post-operative cognitive dysfunction. They're able to go to the bathroom and things because they're not on opioids, all the wonderful benefits. So it's very customized, tailored, thoughtful, and really focused on neuroinflammation. The next step of that is all those things that we talked about from hyperbarics on down the line. Those are really helping my surgical recovery from the physical procedure. But interestingly, they're also helping any neuroinflammation that's present, right? Your best bet from a neuroinflammatory state is to get in a hyperbaric chamber. So whether that's a mechanical injury or anything else, so we get the double benefit with that as well.
That's amazing. Thank you for humoring that fairly technical question. I do appreciate it. Dr. Chesnut, I will get that right.
Nailed it. Got
it. There we go. I want to be aware of your time. Before I let you go, though, would you mind running through a few rapid-fire questions quickly?
Yeah, let's hear them.
Molecular hydrogen, it's getting a lot of buzz at the moment as a selective antioxidant. Do you have any personal experience with this compound? Do you utilize it with your patients? Any feelings there?
Yep, I utilize it personally and I utilize it with my patients. This is part of when they come stay with me in their recovery experience in the homes that we have them in. I have hydrogen water in there for them. It's another one of those highly likely to be helpful, but very much a neutral to a positive, if nothing else. And so I view it that way, and I do use it with my patients and I use it myself.
Perfect. If you could recommend one daily practice to support the aesthetics, what would it be?
Sleep really well. Yeah, that's maybe not what people are looking for. But if I could be real simple, and that just honestly just kind of is a window into the whole metabolic health part of things, that like what we look like as a window to our overall health and physiology, I would say that. This is an intricate question that we didn't get into as well, but like UV protection is like, again, our skin is different than our liver and our gut and its exposure to UV. I will be very clear, I do think that the sun is wildly essential and beneficial to us from the way it interacts with our central nervous system via our retina to vitamin D production in our skin. So I'm not saying 0% saying don't stay out of the sun. If you talk to a lot of like dermatologists that are, covered zero sun exposure whatsoever, I don't think that's how we're built to live. But myself, my skin tone, I'm also not built to be out on the equator at noon, right? So we have to just be mindful of that, I think, a little bit. So I would say that. And then what everybody's looking for, I think I kind of already hit, what everybody's looking for is like, from a topical standpoint, think about like a retinol, an antioxidant, or GHK copper.
Yeah, no, that's interesting. So what you're saying is you're not out there with the quantum biologist sort of sunning yourself for 20 hours a day and yeah.
Yeah, I again, back to that, the truth lies in the middle somewhere.
Of course,
a little bit.
Yeah. I agree with that personally. Okay, the trend you see clients wasting the most money on at the moment?
Oh, geez. I have two answers for this. One of them is fillers. That's like most people, dermal fillers made out of cross-linked hyaluronic acid that get injected into your face. That's usually the first gateway into like anything real from a cosmetic standpoint. You can go to any corner of whatever town you live in and find somebody who injects these things. they are one of the banes of my existence from in a surgical standpoint, is managing the complications that they create long term, which are really subtle and insidious. They're like they boil and over time. So that's one. And then the other bigger, more acute one is, I think, any device, like whether that's I don't know, a laser or micro needling, radio frequency, anything that is said to lift or tighten our skin or our deep layers. If you have sagging, gravitational sagging, no device is ever going to lift that up. It's flawed logic from the get-go. At the very best, you just waste your money. And in the worst case scenario, you damage the structure of your deep soft tissues, which again is another thing that I'm managing all the time.
Delightful. Okay. And I suppose in stark comparison to all of that, what's the one sort of regenerative technology that you're most excited to see in the coming years?
Yeah, I think that the use of our autologous stem cells, which I mentioned a couple times in passing, I think that that is going to be, again, we talked about a few things that I'm really excited to see where they go down the road, like NAD and things like that. I think that this is going to be one for us that is going to blossom into all of its uses. And I'm exploring this deeply already, from their individual capacity, just by themselves, like we talked about, injecting them into skin where nothing else has happened. But I'm really interested in using them in how they're having that regenerative interaction with also what's happening with surgery and helping the healing from the surgical process. So I think that going back to your first question about fillers, right? People want volume and they want these things. I think that this is going to be our long-term answer to that without having to put, a gel on our face.
Perfect. Dr. Chesnut, you've been an absolute star, and I can't thank you enough for your time. Aside from people just typing your name into Google, which will probably do it, where would you like to point people to, should they wish to obviously find you, work with you, and all that good stuff?
Yeah, I'm most active on Instagram. And so that's where you'll find the most content like this and see those before and after pictures that I briefly mentioned. And there's lots of content like what we're talking about on there. So, and how it ties in very specifically to my world and my lens. So, that would be the best place to look. And I always start everything virtually. So again, all my patients travel. So it's pretty easy to engage with me without having to fly to me to start things off.
That's brilliant. And we'll be sure to link to all of that in the show notes as well. Thank you so much for your time. It was an amazing conversation. And yeah, thank you.
Yeah, thanks for having me.